Good morning, Dr. Dorris.
Good morning.
To start off, could you tell me where you went to medical school?
I went to Cornell Medical School, now called Weill.
When did you graduate?
Graduated in 1956.
And when did you start practicing here in Worcester?
1963 in January.
What did you choose as your specialty in medicine?
Internal medicine and subspecialized in pulmonary diseases, and became increasingly interested in allergy.
So what made you choose your specialty?
I was interested in pulmonary disease because my father died of cancer of the lung at age 52. A very close friend of mine was a pulmonologist. When I was in the Army, I applied for and was fortunate enough to get a position at Valley Forge Hospital as a pulmonologist, and it was a very intensive time for me.
So describe a typical day when you first started practicing here in Worcester.
Very much the way it is for me still.
Okay.
Get up early in the morning. I go to one hospital. Now I go to two hospitals. I would try to be in the office sometime between 9 and 9:30. And that hasn't changed very much.
So did you ever make a house call?
Yes, I made a number of house calls my first year or two, but not after that.
Did you use the telephone to talk often with patients?
Yes, we use the telephone a great deal, and we still do. If it's a new patient, we try to get them in as soon as possible if they're sick, and if not, we give them enough medication to evaluate the problem in a few days. If they're a real emergency, we bring them to the hospital, but I think there was a real effort made to keep people out of the hospital when I first started practice, much more so than now.
When did you go to the hospital?
I would go to the hospital between 7:30 and 8 o'clock. Most of the time I was there at 7:30, same as now.
Okay. And what were your rounds like there?
My rounds were different in one respect. When I walked in to the nursing station, the nurses would stand up. And of course, if you asked for a chart or anything, they would immediately turn over the chart that they were working on. You don't have that anymore.
And when did you have office hours?
I had office hours usually starting at 9 or 9:30, and they would progress till 12 o'clock. I might run over a little bit, but then I would start again at 1 o'clock and run through to 5. And that's a pattern I've persisted in, except that I no longer work Wednesday mornings, and I try not to work after 3 or 4 on Fridays.
So what do you think it was like for your family to have a physician in the household?
There were a lot of telephone calls. There were interruptions during dinner. There were times when we couldn't get away where other people could. When I started out in practice for myself, after a 2 years partnership with another physician, it was two-man coverage. Today we have a coverage group of 8 physicians. Many of us make our own hospital rounds if we have a number of people in the hospital. I'd say at least half the people in my medical group do that. But originally it was a one-on-one, and I had 2 physicians in our coverage group.
So generally, who were your patients?
My patients, when I first started, were the same as it is now. A mixture of patients who were locally, a mixture of patients who use me as a primary source of medical care, and specialty referrals. And the ratio has fluctuated between 40% referrals and 70% referrals. Right now, about 65% 5% of the patients I see are patients of another primary care physician.
So most of them came from the Worcester area?
I always have had a large number of patients outside of Worcester.
Okay. Did patients have the opportunity to choose their physician?
Yes. Patients were free to choose their physicians. There was no fixed affiliation, which was mandated by the insurance policy, as there is now. They weren't HMOs until about 12, 13 years ago.
How many patients of yours were in the hospital at any one time?
In those days?
Yes.
I would say that when I started practice, I had one patient in the hospital, two, but within a few years became busier, and we put more people in the hospital. We had something in the old St. Vincent Hospital that was called the self-care unit, and we would laugh about it now, but patients would come in and get the diagnostic testing because the insurance did not pay for diagnostic testing outside of the hospital.
So what made you decide to become a doctor?
I'd always wanted to be a doctor from the time I was 5 years old.
And once you started practicing, what made you keep being a doctor? What did you like about medicine?
Medicine is a wonderful field because you have an intellectual challenge, particularly in internal medicine and the subspecialties. It's very challenging. It's like doing puzzles. It's never the same day after day. Sometimes there are emotional difficulties that you have to deal with in the patient, but if you approach the medical diagnoses as a series of differentials, sometimes you take the straight path and sometimes you take a crooked path. And that's the greatest challenge in medicine and the most satisfying one.
Why did you choose to practice in Worcester?
I was interested in going to join an established practice in pulmonary disease and internal medicine with a mixture of both. I joined another physician. It turned out the other physician was a good doctor, a fine clinician, high academic and personal standards, but he'd had 2 heart attacks, and it was his wife who had solicited for him to have a partner. And after a while, we felt it was best if we just separated.
Do you have a favorite memory from when you practiced, or from your whole career?
No, I have no single favorite memory.
Okay. How about a least favorite memory?
My least favorite memory was the first time I encountered an unexpected death in a patient for whom I had been caring. I remember days and days of soul searching to find a diagnosis or a test that I could have envisioned which would have prevented the death. I don't even remember if I found one, but I remember feeling very, very bad about it.
Okay, moving on now. Would you tell me what were the most typical illnesses that you dealt with when you started practicing?
I think that the illnesses were very similar to what they are today. I do a lot of pulmonary and allergy, and people still sneeze, cough, wheeze. It seems to me that sinusitis is much more common today than it used to be, and that we're much more aware of it. There was much more environmental illness in the sense of people being sick from their homes, their environment, and from their jobs. Since 20 years ago, when OSHA first came into effect, employees have to be told when they're being exposed to something that's potentially injurious.
Yes.
That's made a big difference.
So you're still treating mostly the same illnesses that you did when you started practicing?
But treating it much more effectively.
That's good. Yes. What was the greatest challenge for you to treat when you started practicing?
The hierarchy of medicine was different than it is today. The hierarchy of medicine was such that you had to earn the respect of your colleagues, and if you earn the respect of your colleagues and practiced good medicine and treated patients honestly, they in turn respected you, and you would be able to climb the ladder of mutual respect. Today, I think that's been replaced to some extent by mandated agencies that look for performance standards, not only based on the quality of medical care, but upon how good you are at saving a hospital or an insurance company money. The second thing is that there was a great deal of respect for people who had been in medicine for a long time and had been practicing in the community, and young people had to come in and be accepted. And it wasn't just a matter of practicing medicine, it was a matter of whether you were a reliable person and whether you fit in. If one hospital had one particular way of doing things, then they wanted people who joined their staff to do things in a similar way. This is much more of an open society today. What restrictions there are not those that are imposed by physicians, but those that are imposed by institutions and the insurance companies that the institutions help to run.
So gaining the respect of your colleagues and being regarded highly in your field was more of a challenge for you than any one disease or illness that you treated? Is that what you're saying?
I'm not really saying that. I'm just saying that the emphasis has changed.
Right. What was one of the most important...
What I'm saying is that I really think that medicine was regulated in the days I started practice by the covert pressures of one physician against another, and not by the regulatory agencies. It was a small community, and many physicians knew very closely what the other physicians were doing.
What was one of the most important breakthroughs in disease treatment during your career?
Well, take asthma. I think our treatment of asthma has just radically changed. We have purified, standardized extracts if we're doing allergy work, and that's of an enormous importance, because in the old days when you got allergy extracts, whether it be testing material or material for allergy injections, they could vary from company to company, and even within the company could vary from batch to batch. Now they're standardized, extremely reliable products. The medicines we have are based upon a scientific understanding of the disease processes. In the old days, asthma was just a disease of bronchospasm. Today, it's a disease of inflammation. And we used to say if you have an asthmatic, you could wheeze along the rest of your life and there wouldn't be any changes. Now we know that there's remodeling going on, that you have to treat asthmatics very, very vigorously. As an example of the change in medicine, our entire concept has been altered. There have been other changes too. When I started in practice, if you had an ulcer, we would give you a sippy diet, which was very high in high caloric and in high fat content like milk. You drink large quantities so that to ease the ulcer. Now we have medicines which prevent acid from forming and are very, very effective, far more effective than what we used to have. In diverticulosis, when I started practice, the first thing you would do is you take somebody off nuts and salads and high fiber. Today, once you get over the acute episode of diverticulitis, the patient is said, You could gradually increase your whole grains, gradually increase your salads, still avoid nuts, but after a while we're depending upon eating those foods to keep your bowels moving regularly and preventing you from having a recurrence of the diverticulosis or diverticulitis. So there have been a number of changes.
Yes. What was the worst epidemic that you can recall?
The worst epidemic was when I was a senior resident at Philadelphia General Hospital during my residency, and we had a flu epidemic. And I had 105 interns and house of physicians, and a number of them got extremely sick, and some of them came close to dying. And I think that was something we just couldn't do anything about in those days.
The interns and the physicians getting sick.
That's right.
Could you describe attitudes towards smoking and cancer throughout your career, as well as your attitude?
Well, in 1962, the insert from the inserts that were put in cigarette packs that smoking was bad for the patient was implemented. Secretary, who was Dr. Koop, who did that. And from the time I went into practice, I began working with the Lung Association. I've had a long affiliation. I'm still on the executive board, on the general board. I'm a program chairman for the state, and done an awful lot with cigarette smoking for the medical society here, along with other physicians who've been very interested. And I think what we've done is we've seen a change in the public attitude, and perhaps we've had a small part of it. The change is that smoking was regarded as an individual right and one of the basic freedoms that are expected by an American. And today, the emphasis is on the other person's rights. If you're not damaging yourself, you're damaging other people with secondhand cigarette smoke. And that's been a wonderful program and a wonderful point of view. Also emphasizing the importance of not smoking for pregnant ladies, so that they're not injuring the baby. Even though they don't care about themselves, they do care about the babies.
Okay, in terms of technology, what is something that doctors take for granted now that you didn't have at some point in your career?
Well, probably things like fiber optics, laparoscopic surgery has been one of the major advances. The other one has been the imaging. Radiology has moved from röntgenograms to various devices for seeing inside the body.
What technology is still being used today that you used frequently in your practice?
Well, the spirometer is a basic tool. In the old days, the spirometer was run on something very much like a laboratory instrument, where you had a drum which spun around, and you had a pen that wrote on it. The patient blew into it, and the drum moved, and the pen wrote. Now it's computerized. So what used to be a laborious process of calculation, it's now instantaneously done, and it's made the tool much more accessible. It's still underused, but it is much more accessible. The EKGs used to be a machine that you had to really fiddle with. And today, you know, they're standardized and they're extremely reliable.
Describe one important invention that you've seen.
The laser for diabetic retinopathy comes to mind immediately. When I started in medicine, diabetics frequently would go blind. And today we don't see that because of prophylactic laser treatment of diabetic retinopathy.
When did that come into use?
I don't know. 15 years ago, maybe, 20.
Did you always have access to the new technology in your field?
Pretty much.
Okay.
I run a laboratory here. Now it's completely automated. In the old days, I had to build the equipment myself. Fortunately, I had backgrounds where I could build a body plethysmograph and other electronic equipment. Most of the electronic equipment was developed for the astronauts, and we were able to apply it to medical use. I think there was very little technology that wasn't available. The big change has been the imaging techniques that are now used by the radiologists.
What would you like to see invented in the field of medicine?
I never thought about it.
What were some of the most important drugs that you used throughout the course of your practice?
Well, that's an interesting question. Epinephrine was a very useful drug, and probably still is, but it has serious side effects, and if you keep using it, the patient has not only an increased risk if they're elderly, but they get decreasing effectiveness. In asthma, we've changed over to medications which are much more potent and much longer acting. We have new medications for asthma, which are beta agonists. We now know what a beta agonist is. We had no idea why adrenaline worked.
Yeah.
We didn't understand the receptor. Today, we not only understand the receptor, we've seen very complex diagrams of the receptor, and it's been cloned. They can grow these things. Then they can fiddle around with them and make changes and then find agents which will block them. So the development of drugs and the development of the science is on a completely different level. Theophylline is a drug we used a great deal. We still use it sometimes, but it was a very difficult drug to use and required a certain amount of skill. Because of that, we're using it a great deal less. Steroids were used, and we had terrible side effects from steroids. And we've been able to reduce that with inhaled steroids.
Did you always have access to the drugs that you wanted to use?
At least as much as we have now. We have many more drugs available, but the cost of drugs was much, much lower. I remember buying generic tetracycline, maybe $3 100. And today I would think that you'd have to pay a great deal more just to get a pack of 20 or 30 of them.
Yeah. Well, that's just part of inflation, right?
It's more than inflation. The price of pharmaceuticals has gone up disproportionately. When I was involved in Central Mass Healthcare in 1988, the total premium was about 40%, maybe 50%, 40% of what it is now. The percentage of the premium that was set aside for pharmaceutical costs was 5.5%. Now it's almost 20%. And of course, the total cost has gone up a great deal more too, but the percentage that's devoted to pharmaceuticals has increased enormously.
Is there a single most important breakthrough in drugs that you've seen throughout the course of your career?
No.
Okay. How did the changes in drugs in the drug industry affect your practice?
Well, I think the biggest change is that many people can't get the drugs, and we're very much dependent upon a good relationship with pharmaceutical representatives or with the pharmaceutical companies to supply us the drugs free. Many patients are encouraged to get their pharmaceuticals if they're at the lowest level of the economic ladder. But some of the insurance companies will allow drugs to be paid for, but it's a very small amount that they can pay, and once they exceed that, the patient has to pay a great deal more. We end up having the patient buy the prescription every other month and get the free samples in between. We have to be very selective about ordering a brand name medication when a generic can replace it. This is particularly true when you're going for somebody who will take a pill once a day as a convenience item, and it costs a great deal more to buy the single pill than it does to buy a generic that they take 3 times a day.
How did patients without money get health care?
Free clinics. And free clinics worked. They were good. We devoted our time to free clinics, and we felt good about it. I trained part of my training in a hospital with free clinics. And the patients were respected, they were treated nicely, there was nothing dehumanizing about it.
How about patients without insurance?
Same thing.
Right. So do you think everyone...
If unlike most of the guys I know in practice, if a patient is my patient and loses his insurance, I carry him. I give him free samples. And I would say that at least 80% of the physicians do the same thing. That's the standard rule.
Yes.
And nobody tells us to do it. We just do it.
Yeah. So you think everyone who needed health care got it?
They got it. They got in a clinic setting, and it was good for the interns and residents because they got the experience. And of course they were supervised. And the supervision was much closer than it is today.
Over the years, how do you think Worcester compares to other places in terms of providing care for the underserved? If you can make any comparisons.
I think Worcester has much better medical care than most other places in the country. And as a measure of that, people come from the surrounding areas to Worcester.
What were some fears and concerns about socialized medicine in the 50s and 60s?
There were concerns that socialized medicine would dramatically change the practice of medicine. And medicine in those days was really a relatively stable field of work. Today we have the sense that things are changing and changing all the time. And we are completely used to an insurance company saying this is our favorite drug and that was our favorite drug, and you have to change all those people from last year's drug to this year's drug. We expect change, but we did not expect change when I started out in practice. As a matter of fact, I think it gave a great deal of social stability. Not only did you feel as though once you fit in, you stayed fitted in, but it gave a great deal more security. You knew pretty much how to act and how other people expected you to act. And that was an understanding that went back and forth several times. You knew the way a doctor was supposed to behave, and there were very few exceptions. I think things are just changing very rapidly, and people don't know how to think, they don't know how to act, and they don't really have any sense of where the future is going to be.
So were physicians ever involved politically on the topic of socialized medicine?
Yes, they were. They weren't my friends. I didn't know about them. I knew that there were people in this community who were very active politically.
What were your feelings on Medicare and Medicaid when they came into being?
I welcomed them.
And you still feel good about the programs right now?
I feel very good about the programs. I think although the pharmaceutical costs are a major problem, I think that the medical care itself has changed dramatically. I mean, I remember people who did terrible things in order to get medical care. They sold their houses. They, did things that people wouldn't have to do today.
Do you think the government has become more or less involved in healthcare throughout your career?
Well, it was inevitable. If the government started to pay the bills, they were going to supervise and question the way the money was being spent. I think what's a legitimate complaint we have today is that some of the ways this is being done are not ideal. My understanding is that some of these regulatory agencies are looking for outside support to come in and do auditing, and that the auditing then is done not by a disinterested party, but a party who gets a percentage of the audit fine. And I don't think that's right.
So, what would you like to see happen with the government in healthcare?
I think the government is in healthcare, and I don't think it's going to get out. I think it's going.
You want it out.
I don't feel I don't think it's a matter of wanting it out. I don't think it's going to happen. But what I'm saying is that just as physicians have to be regulated to some extent, and that regulation now is coming from outside of medicine, well, when I started, it came from inside medicine. There might be a bad apple here or there, but by and large, most of the doctors stayed in line, and they stayed in line because of the covert pressures of their peers. Yeah. It's not like that anymore. And I think that you're going to find an imbalance that I see growing, that the government has a little bit too much power, and that somebody's got to be able to get back and control the people who are doing the inspecting. I think the regulatory agencies have a little bit too much power.
How did HMOs first impact your practice when they came around?
They had an enormous impact on my practice. It was to my benefit because I was absolutely too busy at the time. And the first impact of an HMO was to tell a primary care doctor, you should do as much as possible yourself. And the training programs, the residencies programs here, suddenly turned around from saying you should work with a consultant or you should work with a specialist, and a primary care doctor should be a specialist in every field himself. And to some extent, that ended up with physicians who were better trained and better experienced. It raised the notch for the primary care doctors. But for somebody like me, who drew a certain amount of his income from referrals, I've noticed an immediate drop.
So would you like to comment further on the positive or negative aspects of HMOs?
I like them. I think they're good. And I had to adopt them personally, but that was a sacrifice that was necessary for the system.
Okay, well, back to your personal life now. How much did it cost for you to go to medical school?
I don't remember. I know my college tuitions. My college tuition was $500 my first year, and my second year in college it was $550, and for the last 3 years it was $550. And I think tuition at Harvard now is about $25,000.
Yep. So obviously the cost of med school has gone up over the years, but how do you think the costs today influence choices of young doctors when they graduate compared to costs back then?
I have no idea. My daughter went to medical school. I paid for, she was married. I paid for a part of it, and she took out loans for the rest of it, and she is still paying them off.
Has that influenced her at all in terms of where she would practice or what she would choose as her specialty?
No. No. She's an internist, and she's an internist because it's intellectually challenging.
How How have doctors' salaries changed over the course of your career?
Well, when I started in practice, my first 2 years, I was on a salary, and I left, went on my own, and I've been in my own ever since then, so I don't have a salary.
So where did most of your income come from in the early part of your career?
From patient care, and a lot of it came from insurance.
And it's still the same now?
It's still the same now, yeah, that's right.
How has malpractice insurance changed over the years?
I think malpractice is something that physicians live with. Some physicians have more malpractice problems than others. Partly that's because of the work they do. Neurosurgeons, obstetricians. I think when the people who are least likely to be sued are the primary care doctors who take care of people and have long-term established relationship with them. The other problem about malpractice is that there are a lot of advertisements on television and radio of
Yes.
lawyers who specialize in it.
So what were the typical fees for an office visit when you began practicing?
$5 for a revisit.
What out-of-pocket expenses did you have for your practice?
I had everything. I had to buy a desk, a chair, bookcase, pay for the telephone in advance, hire a secretary, get a typewriter, have stationery printed up.
So how did you learn the business of medicine?
I was in practice with an older physician for 2 years. I watched him. He was a good businessman.
What are some changes that you've seen in the demographics of the Worcester community?
The demographics of Worcester community, huh?
Yeah.
Well, we had no blacks here when I came. I think it was less than 0.5%. And now we have a sizable representation.
Yeah.
And the Hispanic population has increased a great deal. The Indian population, the international community has enormously expanded.
Has that been the case with the ethnic background of your patients over the years?
Yeah.
Okay. How did women's health in Worcester change over the course of your practice?
I think there's been much more attention to women's health.
Have there been changes in how children are cared for at all?
I don't see kids.
Okay. So you can't really comment on that.
No, my impression is that the pediatricians have always been overworked, underpaid, and that under-envied. I think we've always felt sorry for the pediatricians because they work very, very hard, and they have an awful lot to do. Now they have nurse practitioners with them.
How has Worcester been different from other places that you've practiced?
Well, I only practiced in Philadelphia, Syracuse before I came here. I went to medical school in New York City. I went to Cornell.
Yeah.
So I don't have the kind of experience.
Okay.
Yeah.
What were public perceptions of doctors when you started practicing medicine?
The public was much less educated about medical care.
Mm-hmm.
Now, a patient can get information on the internet. I must have a patient every week or two who comes in and gives me a portfolio of papers that they picked up about their disease on the internet. And they don't ask me what I think of it, whether I think it's accurate or inaccurate. They present it to me like, well, I thought you might like this, so you could learn a little bit more about what I've got.
So they're teaching the job.
Yeah.
Okay. How do you feel the role of the physician in the Worcester community has changed over the years?
I think the Worcester physicians have always tried to give not only individual but community guidance, and we still do. It's not always seen, but the medical society tries hard. We try to give guidance and support about smoking, about drugs, about health care for the indigent, the people who are infirmed, people who don't care about themselves. I think we do a good job.
And how's the role of the physician in the community stayed the same?
Well, it's much more fractionated. When I started in practice, there were very few full-time employees. There are very few hospital-based physicians, and now hospital-based physicians have become a group unto themselves.
That's right. Are there Worcester physicians that you admired when you started practicing?
Yes. There are some I really admired very much.
Older physicians generally?
Yes.
How about now?
It's still the case. Not older than me, but
Yeah. What was it like for the female physician in Worcester in the 50s and 60s?
we'd had very few. In my graduating class at Cornell, we had 85 or 86, and we had 5 women. Today the classes are 50 to 55% women.
How did group practices or hospitals treat minority physicians when you started practicing?
There were very few. There were very few.
So how do you think that's changed?
I think it's part of the internationalization of the Worcester population. Worcester was a second largest city in the community at that time, second largest city in New England.
Yeah.
I think it was the same size or larger than Providence. Springfield was a little bit smaller, but Worcester was still a big town that acted and thought like a small town. I came from New York City, and to me this was really small town mentality.
No, it's a big city.
Yeah.
So what do you like best about practicing in Worcester?
Worcester's a very nice community. It's really a very nice town. It's a very nice area. Most of the people here are really very, very nice. I think it's a wonderful place to be.
What do you like least about the Worcester community?
Nothing.
Okay. Well, before we finish, are there any experiences from medical school or throughout your career that you would care to share?
Yes. I think that when I went to medical school, it was extremely difficult, and it was meant to be difficult. The internship was meant to be very, very difficult, and it was like becoming a Marine and going to Guantanamo Bay. And it was part of the experience. If you survived it, you felt you had accomplished something. Today, it's just another year of training. And the physicians who go through it come out with a feeling that, you know, it's an ordeal, but it's not something which really molded their character. We would work long, hard hours, and there was no question that there were times when we weren't able to exercise the best judgment because we didn't have enough sleep. Those things are not possible anymore. And I think, although it's better for the intern, it's better for the patients, in changing the experience, I think little is lost.
So you don't feel that they come out as better prepared as you did?
No, I felt as though I was joining a brotherhood when I became after I finished my residency. And I still keep close contact with a number of people with whom I interned and took residency, and people with whom I trained.
Is there anything that you'd like to share from your military service? You didn't really talk about that too much earlier.
No.
Okay.
I had a good 2 years.
Would you like to comment on how your specialty, how your field has changed over the past 50 years?
Well, in pulmonary disease, started out as a rather inconspicuous field, and we didn't have very much technology, we didn't have very much we could do, and now it's become a major subspecialty with a lot of gadgets and a lot of things we can do. And I think that's a good evolution.
Well, lastly, Dr. Dorris, what advice do you have for younger doctors just starting out?
Yes, I have some advice. I have the advantage of having discussed this with my daughter a number of times. My daughter started out as a carpenter, a cabinet maker, and she was making museum quality pieces, and for personal reasons decided to go into medicine. And we had lots of talks about medicine. And what I told her was that she should not look at the money, and she should not look at the prestige or social standing of the specialties or primary care, but she should do what she would like the most. And I would say that to anybody else. If you enjoy patient contact, then pick a field where you have patient contact and where you will be enjoying a continuing relationship. If you're someone who wants to be looked up to, then become a consultant. You won't have to deal with continuing relationships on a long time. Look yourself in the mirror and decide what's good for you and what will give you the most continuing satisfaction, and that in the long run will make you a better doctor.
Of course. Well, on behalf of the Worcester District Medical Society, thank you very much, Dr. Dorris, for your time, your words of wisdom.